So I'll just be beginning my talk now. So good afternoon, everybody. So this talk is about the new generation of EDOF IOLs that we currently have at our disposal. So this one IOL that we've been using quite frequently in practice now, and I'm just going to describe our experience with it. So we know now emetropia is probably the cornerstone of any refractive cataract surgery, but now the standards have increased. Emetropia doesn't mean free of glasses just for distance alone. We also need to target emetropia for near. The real challenge is to provide this without any added photic phenomena, without any contrast, and without any light loss as well to our patients. And now as our generation demands, intermediate vision, the tasks that we're doing at a computer range, at a tablets is now becoming more important than the real reading tasks that we do with our mobile phones or with our newspapers. So intermediate vision is something that our patients really demand nowadays after cataract surgery. And the definition of an EDOF IOL is still a little ambiguous. So we have a refractive design, we have diffractive designs, and we have designs based on alteration of spherical aberration. But truly, an EDOF must not have any rings on it. It must not have focal points, or it must not be really diffracting light. So we have very few options in this regard. The IOL I'm talking about is called the Swiss 4 IOL made by Appasamy. So the design of this is an aspheric optic. The real difference is that the center alone is steepened to induce a controlled amount of spherical aberration, whereas the posterior is an aspheric design. So we must first understand how this IOL works and how spherical aberration can be used to our advantage. So the way these IOLs are designed is the anterior surface has a higher order aberration, which is spherical aberration. This is achieved by doing a gradual central steepening from the center to the periphery. So what happens is the periphery has lesser steepening, whereas the center has more steepening. This will give rise to spherical aberration. So we must first understand what exactly spherical aberration is. So unlike the other higher order aberrations like coma or trefoil, spherical aberration is naturally occurring. We have it in our eyes by nature. It increases with age. As the lens gets more spherical, we get more spherical aberration. It will also increase with accommodation. So when you're accommodating and look at near, the zonules relax, your lens gets more spherical, you get more spherical aberration, and that extends your depth of field. So by nature, we are accustomed to living with spherical aberration, and it is something that we can tolerate to some extent. So this is how spherical aberration actually works. So just imagine you have a lens like this, which has an increased power in the center and lesser power in the periphery. What ends up happening is the central rays get focused closer, while as the peripheral rays get focused further away. So you end up having a blur circle or a circle of least confusion, which is exactly what you will see in a conoid of Sturm. But in spherical aberration, there's no two axis, there's a single axis. You can just imagine it like a conoid of Sturm, but this is in spheres. So this blur circle will extend your depth of field while giving a minimal compromise in the quality of vision. So how much of spherical aberration is actually beneficial? There have been studies with the adaptive optics which have really figured this out. The amount of spherical aberration that is therapeutic is between 0.3 to 0.6. Anything over 0.6 goes into the toxic zone, which will degrade your quality of vision. But if you are in the zone of 0.3 to 0.6, whether negative or positive, you will get the benefit of extended depth of field without a very noticeable amount of diminution in the quality of vision. So this is an example of a chart with and without spherical aberration. The top chart has no spherical aberration. As you can see, the patient will only have one sharp point of focus, but the images before and after that point focus are all blurred. Whereas in the bottom chart, you can see when the patient does have a controlled amount of spherical aberration, both the images before and after the point focus are in focus, whereas the quality of vision is very slightly reduced, but not too drastically. So how much spherical aberration does this lens have? Okay, if you ask Appasamy, they'll say they have about minus 0.27, like the IHANS. But that's not actually true. When you have an aberrometer like this, which can measure spherical aberration in three different ways. One is lenticular in the lens, second on the cornea, and three in the total eye. So when you look at the eye trace after implanting the Swiss 4 IOL inside, we see the Swiss 4 IOL has a negative spherical aberration which goes up to minus 0.6. And as you know, most of our patients have a positive spherical aberration of plus 0.3, and this ends up having a totalized spherical aberration of minus 0.3, which is in the therapeutic zone. So we did a study about 138 eyes of patients who underwent phaco Swiss 4. At the end of 1 month, most of the patients had 6.6, very few had 6.6 parts or 6.9. Intermediate also, most of them have N6, very few get only N8. And near also, at least about 90% of the patients end up with N6 and about 10% end up with N8. This is the defocus curve. There's no peaks. We have a smooth defocus curve to, up to about minus 1.5 and plus 1. So why does this slight variability occur when you're using read-off lenses? Like I mentioned, most patients have a spherical aberration of plus 0.3 on the cornea. If you put this lens in, the Swiss 4 lens, this has a negative spherical aberration of minus 0.5 to minus 0.6. So you will end up with a totalized spherical aberration in the post-op period of minus 0.3, which is in the target therapeutic zone, which will extend the depth of field, and the patient will get good intermediate and near vision as well. Some patients who have an atypical amount of spherical aberration of the cornea might not fall in the target range. They might get less than 0.3 or they might get over 0.6. So that is out of the therapeutic range and they may not get the benefit of extended depth of field. But the good point is, in our patient population, because the pupils are quite small, this will be a little forgiving, then they might still get depth of field even if they are outside the target range. Contrast sensitivity is quite good. We've measured it on the eye trace of the MTF. Most of the time the MTF value is at 0.5. So I can conclude by saying EDOF technology is the future. As the EDOF IOLs get better and better, they're going to perform better at the near range. Diffractive IOLs, because of the photic phenomenon, light loss, will be on the way out. Swiss 4 is a true EDOF design, no rings. It works on spherical aberration, which gives good results for distance, intermediate and near. If you really want to achieve the best results, do accurate biometry, and if you can measure the patient's pre-op spherical aberration of the cornea, you can really judge if this IOL might be the best choice for your patient. I conclude by saying do price it appropriately as a premium IOL because it is such. Thank you for your attention.
Thanks.